Both these papers are now open for discussion. Could I ask the first author to come up to the stage as well?
Okay. My name is Mark Vierhout. I'm a urogynecologist from the Netherlands, and I'm one of the authors from the FUSIS study. And what I would like to stress, and you didn't mention it in both presentations, that the inclusion criteria for both the value study and the FUSIS study were demonstrable stress incontinence. So they had to show incontinence during physical examination, which is a key point in both studies.
Congratulations for two excellent presentations. My name is Mohammed Abdel Fattah from Aberdeen. Can I just ask about the search strategy which you both mentioned? One ended in November 2012, and the other was, I think, March 2013. And they released quite different outcomes. The large study that was shown to us with 64% effect on the first presentation was not captured in the second presentation, although it was published in May 2012, and I'm talking about NAGER 2012. Similarly, you have presented two RCTs in the second presentation by Van Leegesen. I take these are not additions to each other, they're just two completely separate studies. Thank you.
In answer, sorry, I never picked up the first question. In answer to your last question, the two Van Leegesen studies are VUSIS 1 and VUSIS 2, so they're two separate RCTs.
My first question was, you both applied same searching strategies for the same databases, but you captured different studies. Any reason why you haven't captured NAGER 2012? I'm sure you are prepared for this, having read the abstracts, both of you.
We captured different studies because our study questions were different. My study question was very focused on women undergoing stress incontinence surgery and the role of preoperative urodynamics compared to the Cochrane review, which was more focused on all urinary incontinence in women. I'm sure my colleague would want to support me with this idea.
Yeah, we included any study which randomized patients in one arm to urodynamics, but they could have any form of incontinence, whether it be urgency, mixed, or stress urinary incontinence.
Thank you.
May I? Hello? Mia. Enrico Finanziero from Rome, Italy. Congratulations for your good presentation. I have one comment and one question. For the first speaker, the question. The comment is that we have seen this beautiful meta-analysis, but as the previous talker has mentioned, we have to underline, to stress maybe the concept that inclusion and exclusion criteria for these trials were very strict. So we are talking about a minority of patients. For the value trial, for instance, 66% of patients screened were not included in the study because not having the inclusion or having exclusion criteria. So we have to underline that these conclusions may be applicable only for this subset of patients. In a poster that we will present tomorrow, in our experience, these patients are around 25% of what we see, of the patients we see in our clinical practice. This is the comment. The question is, you mentioned that you should perform urodynamic in patients with voiding difficulties. We have seen in the value trial that there is a 10% of patients, in our experience it's about 20% of patients, having voiding difficulties diagnosed only with urodynamics. So how to include in urodynamics evaluation people, women who we don't know they have a voiding difficulty, and that we can see this difficulty only with urodynamics? I think this is a difficult question to answer. Sorry.
Okay, in the office evaluation, the studies included performed uroflowmetry and post-void residual scan to screen women for voiding difficulties, along with the bladder diaries and focused history. So inclusion of uroflowmetry should pick up a majority of the patients with voiding dysfunction. There was one study which said that if women have normal uroflowmetry, then the chance of having a abnormal voiding cystometry is almost nearly 3%. So based on that, I think it's quite safe to still perform uroflowmetry as a part of office evaluation to diagnose or initially screen patients. Obviously, if they have abnormal uroflowmetry or post-void residual scans, they would still need urodynamics.
So maybe we can agree that at least non-invasive urodynamics are, useful for those patients.
It's not complete urodynamics. There is no filling.
Non-invasive.
Non-invasive uroflowmetry.
Hi, my name is Guillermo Martinez. I work in Slovenia. How do you think, do you think it's likely your findings are going to influence clinical practice, considering many of us do urodynamics anyway before and are likely to still be doing that in the future? That's a question for both of us, actually. Thank you.
Sorry, the question was, do I think the results of the systematic review will influence clinical practice?
Yeah, do you think your results are likely to influence clinical practice in the future?
I think it's important to obviously take the results in context. What I've shown in our systematic review is that urodynamics may change. We've shown that it may change clinical management, so you may prescribe more drugs, but surely the aim of treating a patient would be to treat the condition, and there was no difference in the number of women undergoing surgery, and possibly subsequently there's no difference in the number of women being incontinent at 1 year, and so it might make you question whether it actually does change clinical practice. I'm not sure. I think it would need to depend on updated guidelines, including the new. Incorporating the new evidence.
Julian Shah, Institute of Urology, London. I'm sorry, there's two of us waiting to ask a question. If I may just make a comment. Before you dismiss urodynamics, in this context, you need to discuss which type of urodynamics were used. Was it video urodynamics or cystometry? And then whether or not the urodynamics benefited you in the decision as to which operation to perform. If everybody just does a tape, then maybe you just don't need to do any urodynamics. But if you're going to do other operations which have just as good benefits, maybe better benefits than taping, then I would suggest that urodynamics, and particularly video urodynamics, are crucial in investigating patients.
Kate Moore from Sydney.
We agree with this comment that this review is on focus group of women undergoing surgery for either pure stress incontinence or stress predominant mixed incontinence. When there is a dilemma about which operation to choose or whether there are more coexisting conditions, then maybe there is a case for urodynamics. We did not completely dismiss urodynamics from routine clinical practice.
Hello. Can I ask a question, Sandra? Up on the right side. Hi. Kate Moore from Sydney. I'd like to ask both of the speakers whether you could comment on the overall applicability of these studies to the broader clinical environment worldwide. I'd like to point out that the International Continence Society has spent the last 30 years trying to encourage people to have a standardized approach to the objective definition of incontinence. And for those of us who remember Patrick Bates, 8% of women who leak when they cough will be found to have an unstable bladder. So my question to you is, the studies that were all conducted in quite a research environment, what do you think is the applicability, or do you feel that we should gather more evidence before the international continence community abandons urodynamics?
Sorry, can you rephrase the question? It was quite a long one and I could not understand.
The studies were conducted in a strict research environment. Do you feel that these studies are therefore applicable to the entire continence community, or is further evidence required?
The studies, though they were conducted in a research environment, they were all multi-center studies conducted across 3 different countries. In the value study, majority of the clinicians were fellowship trained, whereas in the WUSA study, it was conducted in 9 non-academic and 1 academic hospital. So it shouldn't change what happens in real life, and it should be applicable, the evidence that has been produced.
I completely agree that the setting in which all the studies were carried out is completely different to standard clinical practice. I mean, the ICS is a worldwide organisation, and some countries some countries obviously don't have access to urodynamics. I think the point about needing further research, that's always the dream. You'd love to have further research. We actually had a statistician calculate how big a study you would need to bring the incontinence rates down to plus or minus 10%, and you would need a study of 3,200 people, so 1,600 people randomised to urodynamics and 1,600 people in the other arm, and that would only bring it down to 10% confidence intervals. So, I mean, you do need a fair bit more evidence, I think I would say.
Thank you very much.
We have time for one more question.
Peter Dietz from Sydney. Thanks for those presentations. There's a lot of data there, and I think you answered the questions very well. I just wonder whether there's one aspect that has not come up. And while I was sitting there, I was considering, what do I take from urodynamics, and how do I use that result to counsel my patients? And really, it got, for me, the bottom line is that the main reason for me doing urodynamics is actually for the closure pressure, because we know that's a predictor of outcome after slings. And many of us would do a transobturator tape unless the MUCP is quite low. And if it's really low, then many of us would rather do a TVT. That's fairly common clinical practice as far as I'm aware. And if somebody's got a really low closure pressure, I may change my surgical technique. But what I'll certainly do is I will counsel the patient accordingly. So if somebody's got a horrible MUCP and a horrible abdominal leak point, then I will prepare them for the higher likelihood of surgical failure. So even if me doing urodynamics or not, it may not change the outcome ultimately, or you need very large numbers to see a change in outcome. What it's definitely going to do is it's going to inform my counseling, so that hopefully afterwards the patient is less likely to be really angry with me or even sue me. Do you see the point? That's one outcome measure that's something like patient satisfaction that's rather difficult to capture, because it depends on the counseling effort of the individual surgeon. And it's always like that with diagnostic methods. They're so hard to test because it's not just the diagnostic method and its performance that matter. It is what the clinician does with it. And we all know we're not the same in what we do with the urodynamic information, both for counseling and for surgical management. So the point is, even if urodynamics may not change your objective outcomes, it definitely helps you with patient counseling and hopefully reduces the risk of your patient getting really pissed off with you once the procedure has failed. Does that make any sense?
Yeah, I mean, the more information, the better. But, I mean, the main question lies in whether that extra information is worth putting the woman or patient through a potentially harmful, well, not harmful, but quite an invasive procedure with obviously the associated risks and the associated costs. And I suppose that's each clinician's own opinion.
Thank you very much to the authors for excellent presentations.